Well, thank you. Thank you very much. I really feel honored to join this meeting and visiting this beautiful city. So thank you. Thank you very much for having me here. And also thank you for choosing a topic that, even if it was not well covered, because there is no many research in the topic, is something that I really like. And I hope that I share with you my passion on portal vein thrombosis. So you asked me to cover both in the presence and in the absence of cirrhosis, and this is like a very important point, because when we have a patient with portal vein thrombosis, we know that not all portal vein thromboses are the same. So it's not going to be the same management if the patient has or not cirrhosis, if the patient with cirrhosis is or not a liver transplant candidate. Symptoms are very important. If we have like a chronic PVT or something that is more recent, if there is an underlying liver disease, and how extensive is this portal vein thrombosis, those are things that really matter in the management. So the first attempt to have a classification was a few years ago in the AASLD guidelines, and trying to really put names on all these things, because it's really important how we classify the portal vein thrombosis in order to be able to check treatment response and doing the follow-up in the patient. And the most recent classification is this one that I'm bringing here from the Baldi group, that is like really assessing and really explaining where to measure and how to measure the occlusion of this portal vein thrombosis. And this is very important, as I told you before, to assess treatment response, because here is where we need more research and more information in how to treat and how to evaluate treatment response. So if we compare a little bit what happened in the patients with cirrhosis, usually it's in the absence of thrombophilia. So this is not a cost-effective test to search for thrombophilia. Recanalization rates are very low, even if we treat them with anticoagulation. Usually our patients are asymptomatic, and doing the screening for HCC, we discover the PVT. And even if we cure the cause of the liver disease, especially viral hepatitis, the risk of PVT remains, and it's well known that it affects the outcome in the liver transplant setting. However, in the patients without cirrhosis, here thrombophilia is super important. We really need to start anticoagulation very early, because this is what will determine the rate of recanalization. Usually the patients are coming, especially in the acute setting, with portal hypertension complications. And in the more chronic phase, we do have a portal cavernoma cholangiopathy that is very challenging and difficult to treat. When we have ascites and the involvement of the mesenteric veins, this is a bad response or a bad outcome in our patients. So if we center now in those patients with PVT in the absence of cirrhosis, here we have like two settings, the recent or the chronic, and it's important to know the age of this thrombosis, because the aim of the treatment is a little bit different. If we are in the recent setting, we want to prevent ischemic complications, we want to recanalize this thrombus, and we want to avoid progression to chronic PVT, whereas we are in the chronic setting, what we want is to prevent rethrombosis. Thrombophilia, and thrombophilia. This is very important. We need to check for thrombophilia in our patients. There is, even when we have another cause, go to search for thrombophilia, because patients, they can have more than one risk factors. And when we do not have anything, please do, if possible, NGS, because this will help you to identify some mutations with low rate in somatic mutations that can also contribute to the disease. Even if you have something that can be attributed to that, like diverticulitis, appendicitis, go and search for thrombophilia, because some of the patients, more than half of the patients, will have also an underlying thrombophilia, and this will impact in the progression and especially in the rate of rethrombosis, and not only rethrombosis in the splenic territory, but thrombosis in other in venous and arterial territories. What are the options that we have if we want to treat this recent portal vein thrombosis, defined recent as less than 6 months? We have anticoagulation, that is the first line therapy. We have interventional radiology, and we have surgery. So what about anticoagulation? If we have a thrombosis in the absence of cirrhosis, we should start anticoagulation very early because this correlates with the rate of recanalization. Here, the rates of recanalization are higher than in the setting of cirrhosis. So this is the first line treatment without any doubt. Of course, CT scan, of course, imaging. We need to search for signs of bowel ischemia. This is a dramatic situation when we have this patient with extensive thrombosis and intestinal infarction. We need multidisciplinary management to call the radiologist, to go with them and assess the CT scan and call the surgeon, because if we find that, we need to go to the OR. What is the role of interventional radiology here when we do have this very extensive thrombosis and we start anticoagulation and we do not really know how to evaluate the response or when to go for more invasive approaches? So those are the most recent papers that we have in the setting, and if you see at the visit table, you will see that everyone is doing differently. So there are like groups doing systemic thrombolysis, other they do local thrombolysis. It seems that most of the group, or what is like the field like moving forward, is like placing a tips first, then you have access to the splanchnic territory, and then you can do thrombolysis, either mechanical or with agents. How to select the patients that they need this treatment is key, because those procedures are associated with a high morbid mortality, and those procedure needs to be performed in center of expertise. When we do that and when we achieve recanalization, the outcome is very good, and we can prevent portal hypertension. Those are data not published yet from the Baltic European cohort, just trying to analyze a big number of patients, just to understand a little bit what happened when you, especially with those patients that you put them on anticoagulation, they do not do worse, but you cannot recanalize this portal vein thrombosis, just to know how many of them they do develop portal hypertension. So not all of them will develop portal hypertension, and this is also something that we need to take into consideration when we are aiming to do invasive procedures, and always check for myeloproliferative neoplasm, because those are the things that will impair the outcome when we have a very extensive thrombosis as well, and when we do have ascites at the presentation or involvement of the mesenteric veins. Those are things that will impair in the outcome of these patients. So those are exactly what the guidelines, ESL and ASLD guidelines cover, is like anticoagulation very soon, anticoagulation at least 6 months, and in those patients with intestinal ischemia without improvement despite anticoagulation, here is where interventional radiology and surgical management are needed. What about chronic PVT? So this has been a matter of controversy in the field in the last year. So should we anticoagulate these patients with a chronic PVT or not? If we do not find any thrombophilia, because if we do, we will anticoagulate. Should we anticoagulate these patients or not? And then the answer is like, you can check for factor 8. And if you have a factor 8 equal or more than 150%, those are the patients that will rethrombose during follow-up in splanchnic and extrasplanchnic territory. It can help you guiding the initiation of anticoagulation in this population, and those data they have been validated in an international cohort. The paper has been submitted for publication, but it seems that factor 8 is a very strong predictor of rethrombosis in those patients without underlying thrombophilia. What about chronic PVT that was not anticoagulated, and then you discovered that in a CT scan? Should you anticoagulate these patients, yes or no? This was another big caveat that now is solved after this randomized clinical trial performed in France and randomizing patients either to placebo or rivaroxaban. And as you can see, patients treated with rivaroxaban, they do have almost no risk of rethrombosis during follow-up, and this is why the guidelines now recommend anticoagulation in this setting. When we do interventional radiology, here there is also like two schools. So there is like the group that always place tips in these patients without cirrhosis and PVT, and there is like more the European way that is not placing a tip but only doing angioplasty. So this is still controversial, and in my opinion or in my experience, when you do not have fibrosis and the affectation is in the main branches, doing only angioplasty is like putting a catheter and opening a balloon in the splanchnic vein, you can restore the flow, and immediately you get all the flow through the portal vein and you can recover the thrombosis. And for me, this would be like my first step. And if I see that the flow is not really coming, then I will end the procedure with tips. But it can be possible only with angioplasty, and this is what is covered in the guidelines. If we do have prothrombotic factors, of course, we have to anticoagulate the factor VIII. I think that this is something that we should incorporate in the clinical practice. Also, if we, after 6 months, if we are deciding whether to stop or not stop, D-dimer can help you taking the decision. And if you have a high, more than 500 D-dimer, maybe you should continue on anticoagulation. And again, interventional radiology, very useful, but in cases of refractory complications of portal hypertension. If we move in the last part of my talk to cirrhosis, here the important thing is to identifying who are the patients that are or can be liver transplant candidate, because here is where PVT really has an impact. We know that especially obstructive, like complete PVT will complicate the surgery and will impact the follow-up after the liver transplantation, and especially in those cases where you cannot do physiological anastomosis because the thrombosis is so extensive. This is one of the studies that was presented in the AASLD meeting, and here is like looking at the thrombosis in the patients admitted to the hospital, and also identifying that this is a negative factor that can complicate the outcome of patients with cirrhosis admitted for decompensation of their liver disease. So it's something important to take into consideration. What about anticoagulation? This is one of the individual patient data meta-analysis that we have out there evaluating what's the role of anticoagulation in this population. And the data that we can see here is that anticoagulation has a beneficial effect, and interestingly, it was associated with an improvement in survival, even if the patient did not achieve recanalization. So it seems that anticoagulation is doing something else that is beneficial for our patients, and not only or regardless of the recanalization of the thrombus. Anticoagulation with what? Here it will depend how sick if the patients, and of course DOACs are not are contraindicated in those patients with poor liver function. But if we have child A, child B, they are a very good option. They are safe, and the efficacy of the DOACs is a little bit superior than vitamin K antagonist, and we are like more and more using DOACs in this population. And again, our guidelines recommend treating all PVT in liver transplant candidates, even small portal vein thrombosis, because you do not want this thrombosis to progress and to impair the surgery in the liver transplant setting, and direct oral anticoagulants are more and more recommended in this setting. Here, when we do decide to do interventional radiology, that usually is when we have one of these thrombosis that is progressing, or when we cannot use anticoagulation, especially in those patients with very, very low platelet count. Here, interventional radiology is very useful and can help us well, so if you look at this figure, you can see how your surgeon will not transplant this patient with this portal vein that is absent, but after recanalizing, we can convert patients that were not candidates for liver transplantation into liver transplant candidates. So here, before I told you that when the patient does not have underlying cirrhosis, you can go for only angioplasty. Here is not the case. Those patients, they do require tips. This is a very complicated tips. And I remember when I started placing tips, how portal vein cavernoma was a contraindication for this placement, and now it's an indication, because we can do that with combined approaches. We can start from the spleen or from the mesenteric vein, and then connecting everything with multiple approaches and restoring the flow in the portal vein. Sometimes we can recover the patient and put the patient in the compensated phase, treating refractory ascites or refractory bleeding. And in other cases, we can make these patients that were not candidates able to get surgery and to get transplanted. And we know that when we do that, they do very well. So patients that are recanalized before liver transplantation, who can get a physiological anastomosis, they do very well. And I think that this is one of the highlights in the field in the recent years, where patients who were not candidate for anything can get transplanted, and we can improve survival in this population. Of course, this that seems like an amazing technique has to be done in center of expertise, because more morbidity and even mortality can happen, and we need to select very well the patients and do in the best trained and expert scenario. This is another abstract that was presented and evaluating exactly what happened with these patients receiving tips with a PVT in the absence or in the presence of cirrhosis, and trying to identify where are the rates of occlusion, because most of these patients, they do have underlying thrombophilia. So these tips requires a little bit of more follow-up and more tips revisions, especially in those patients with myeloproliferative neoplasm and the absence of cirrhosis, to really maintain the patency over long term. And again, this is the evidence that support the recommendation that we have in the guidelines, where especially in those patients with PVT and cirrhosis, where you see that the thrombosis is progressing or not improving despite anticoagulation. Here is where tips can be a very powerful treatment. And just to finalize my talk, a little bit of a challenge, because in patients with cirrhosis, we are all the time treating them with anticoagulation, but this is a thrombosis that has been intriguing me for a very long time. So you give anticoagulation to a patient with a thrombosis in the lung or in the legs, and you put them on heparin, and then the thrombosis go away rapidly. What happened in our patients with cirrhosis is we do not see this effect, and more than half of the patients that we treat with anticoagulation, the thrombosis remains there, and sometimes even progress. Even in up to 15% of our patients, this thrombosis progress despite anticoagulation. So giving the idea that what happened there is a different thrombus, and this has been recently addressed, and we have a little bit of information that the composition of this thrombus in the portal vein is different than the thrombus that happen in other vein territories. stories, and this has been an extensive line of research in my lab, where recently we were able to isolate the endothelial cells from the extrahepatic portal vein and characterize them doing transcriptomics. And what we identify is that what happened to these endothelial cells is that they transform and they become myofibroblasts, and they start proliferating and secreting collagen within the wall. And this is, we think, why the portal vein of these patients got like very, very thick. Then you have a stagnation of the flow, and this is a process called endothelial to mesenchymal transition that it seems to be like very, very relevant, and maybe statins here may have a beneficial role besides anticoagulation. So let's see in the future. Thank you very much. And before I finish, I really want to make you aware, because I could see that there is a lot of interest in vascular liver diseases, in Fontan, in Budd-Chiari, in portal vein thrombosis. So we need your expertise in the Valdi group. I'm very happy to tell you that now we have a lot of red dots also in the US and in Latin America, but still the Middle East, we really need people from there to join our studies, to propose studies, and to contribute with your expertise to the Valdi community. Thank you very much.